you say that the stress level is minimal.
There's no stress. But trust me, the interview is not hard at all because they are recruiting right now. They are desperate for more nurses, going in to observe so many procedures. So the good thing is that you know them, they carry you along.
If you continue like this, I might actually pack my bag from England and come and get job. There are many nursing specialties in the United Kingdom, some of which I am sure you have never even heard about, just like the one we are going to be talking about today. So today, I've got with me a post anesthetic nurse in Scotland, and she's going to be sharing with us what post anesthetic nursing is, the challenges, the good, the bad, the ugly, and just everything in between. So if this is what you're interested in, make sure that you stick around, like this video, leave comments below, share this video with your nurse friends. Hello, Wemimo. It's so good to have you again on my channel. Thank you so much for honoring this invitation.
You're very welcome, and I'm ever happy to come back here to share my skills, to share
Yay.
what I know, because knowledge is, it's good to share your knowledge. There's no point in keeping it. So what, no matter how small it is, no matter how big it is, it's always going to be beneficial to somebody out there. So I'm happy to be back, and thanks for having me.
Thank you so much. Thank you. So basically you told me that you are a post anesthetic nurse in Scotland,
Okay.
United Kingdom. Do you mind sharing with us quickly what is post anesthetic nursing and what does it entails? Info.
So when I say I'm a post anesthetic care nurse, was generated from the style of American nursing. So mostly in the United Kingdom, we don't have post anesthetic care units, which is PACU, PACU. That is mostly used in the United States. If there's any American viewers out here, let me know if you agree with that. So where I work was originally practicing the styles of nursing in the US until obviously the government in the UK took over it. So for post anesthetic care units, we are mainly known as recovery nurses. So we pre-op, we post-op, and when it comes to post-operative care, a lot goes into it. We are more or less like the person who's going to keep you alive once you come out of your surgery, no matter how big or how small your surgery is. We are the ones who are going to make sure you're comfortable. You've got painkillers to make sure we're able to get the most of your pain away. Obviously, every surgery comes with some sort of pain. We can't take all of the pain away, but I can guarantee you we will make your pain much more manageable. So that's basically what a post anesthetic care unit is in summary.
Amazing, amazing. How long have you been working as a post anesthetic care nurse in Scotland?
Yeah. So, in case you all don't know, I qualified in year 2013, and prior to me qualifying, I had my management placement at the hospital where I currently worked. So, as we all know, your management placement could last for 12 weeks or could last for more if you are holding hours from previous placements. So, I was fortunate to be sent to that particular department of the hospital, and at first, I did not realize there was that type of nursing at all because I was already
Mm.
thinking in my mind that I don't want to be a bedside nurse. I don't want to work on the ward because I've had my fair share of placement on the ward. So I guess it was just luck that I was sent to that department. And the first 2 weeks, I was like, I don't really understand this placement. Is this where I should be for my management placement? So I qualified in 2013, and obviously I was there for 12 weeks. I was practically part of the team because we all don't wear blues, we all wear scrubs. So only if you tell someone that I was a student will they think I was a student. They wouldn't have guessed I was a student. So in the last week of my placement, there was a job recruitment fair. And I was like, you know what? The other hospitals that I already applied for through the I think the biggest health department in Scotland will normally recruit students. They will assure you an interview at the end of it. So like a mass recruitment by the Scottish Health Board or whatever. So the option I was given, I was not really feeling it. So I decided to apply to where my management placement was. So in the second week before I finished, they held a recruitment fair, and I decided to go. So I booked a slot with the hope that I would get interviewed. And I remember I was on placement that day and I had to get, and obviously, like, I've got this interview, can I go? And all of the staff, they were lovely. They encouraged me. It's like, oh, when we go, 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 go. You know what? When you finish, go home. So my interview was, I think, was 12 o'clock. So I was asked to leave about half 11. It's still within the same compound. So I went and my interview took about 20 minutes. And it was crazy how I was able to answer three questions with one answer, because at the end of the day I was like, oh, is that the interview finished? So I interviewed for the job, and I don't think I found out till the last hour of me completing my placement. My mentors knew already got the place, but obviously she can't tell me. So it was the last hour when I was about to get sent home that I was told I got the job. So obviously I had the placement in that department. I interviewed for it, and I started working there in September of 2013, and I'm still there till date.
Wow, wow, that is awesome.
Yeah,
Some of us who came from Nigeria or from other
yeah.
parts of the world
Mm-hmm.
where it's not called, I just want to be sure. So in Nigeria, we've got theater nurses, and
Yeah.
for theater nursing, you could be a pre-op nurse, a post-op,
Mm-hmm.
intra-op, or they can be rotating you, if I'm right.
Mm-hmm.
But what will you say is the difference
So,
between, I'm not sure if you
mm-hmm.
actually practice in Nigeria or if you were around theater nurses in Nigeria. So what would you say is the
So,
difference between general theater nurses in Nigeria and
yeah.
then your own particular post anesthetic
Mm-hmm.
care nursing in
Nothing. Yeah.
Scotland? So
Mm-hmm.
is it part of theater nursing? Do you work together with intra operative nurses and
Mm-hmm.
pre-operative nurses? Do you get the
Yeah,
question?
I understand you. So I'm going to run you through a scenario. So let's say, for instance, a patient who is coming into the hospital for surgery gets admitted onto the ward. So we get a call to say the patient is ready, and then I could probably be the nurse who's going to go get the patient. So I go to the ward with a slip with everything. Obviously, I have the details of the patient. I go to the ward, confirm I've got the right patient, confirm what they're getting done, and then I escort them to pre-op. So pre-op is like a pit stop. When all these cars, when they do their racing truck, they have to stop for a fuel or stop for water. So like a pit stop, that's our pre-op. So in that pre-op area, I'll bring the patient there. The patient has the chance to meet the anesthetist, has the chance to meet possibly the surgeon, will meet a few of the member of staffs that are going to be in theater. So some of the staffs that are going to be in theater includes the nursing associates. The nursing associate is whom we know as the anesthetist assistant. The anesthetist will have an assistant. So that person will be working alongside the anesthetist. We have a theater assistant. So theater assistant will probably be the errand boy in theater. And then we've got the nursing associate who are going to be keeping an eye on observations and all of that. We've got scrub nurses. I don't get to meet all of them, but they are all in there. So a few of these people will come out. They take an handover from me. And while the patient is in pre-op, the anesthetist will come round and pop a line in their hands if they need a cannula or if they need an arterial line. They put all of that in. And then once I give an handover to the teams from theatre, which would involve the nursing assistant, the theatre assistant, possibly the scrub nurse as well, or the anesthetist assistant, either four of them will come out to get the patient from pre-op. And then once they are satisfied with all of the documentation, with everything like handing over, they then escort the patient into theatre. So that is where my own job stops. So I don't go into theatre for nothing other than to collect the patient when the surgery is over. And me going into theatre is dependent on the type of patient. So if it's a general patient, I don't go into theatre to collect the patient. The anesthetist and the staffs from theatre would escort the patient out on a trolley into recovery while I'll be waiting for them. So if the patient happens to be an orthopedic patient, I would have to go into theatre to escort the patient back, and the anesthetist will have to come with me because obviously anything could happen. The patient is still drowsy, and they would have to come with me so we get into recovery. They give me an handover, they go and I recover the patient. So we don't ever, for me, I don't ever have to go into theatre to scrub or to help the anesthetist or do any task whatsoever in theatre. No, I don't do that. So my main job is to get the patient from the ward, pre-op them, post-op them, ensure they are comfortable, and then ensure they get back to the ward. And once they get back to the ward, that's where my job ends with that patient, and they go back for the next one. So it's like a conveyor belt.
Wow, wow, that's awesome.
Yeah.
That's cool. So what will you say? I think you mentioned part of it earlier, but I just want you to reiterate it. What will you say you love most about this job, and what are the challenges that you faced, and how have you managed them?
hmm So for me, I would say obviously having been a student in that department really helped me a great deal. Like I got to know a few of the anesthetists. Trust me, not all of them are friendly. And I pray none of them come across this video. Not all of them are friendly, and there are some good ones as well. So while I was a student, I kind of like got familiar with a few of them, and I know some by name. I know some by their face, obviously by their face. But then, we the way the staff from the theater and us is more like we have like a love hate relationship. Like we are just there for each other. Like if they don't have us, their patients can't go into theater. And if we don't have them, we our patients from the ward can't come for their surgery. So since I started there, the most challenging part of it all is when you will go get a patient from the ward, and peradventure the patient has been cancelled, but we've not been told. So you can imagine me being in the room where the patient is on the ward, and I'm saying, "Oh, I've just come to get you ready for your procedure today. Could you confirm what procedure you are getting done today?" I'm doing all of that check, only for me to bring the patient down, and they're like, "Osh, osh," and I'm like, "What's going on?" And then they call me to say like, "Oh, wait a minute, the patient has been cancelled," and I'm like, it took me about 15 minutes while I was trying to get the patient ready, and none of you thought it was like you could have called us. The thing annoying about the thing is that changes happen and they don't communicate it to us who are in PACU. They don't let us know until the last minute, and we're like, but you had enough time to have let us know if this surgery for this patient is going ahead or not. So that's the most challenging part, because you can imagine if a patient has traveled from a far distance. We have some people traveling from Holborn, from Edinburgh, Aberdeen, Dundee, all the way to come get surgery, and then at the last minute, and then they are fasting from the night before, only to be told that they've been cancelled. You've wasted their time. So for me, it gets a bit overwhelming for me that I have to comfort this patient to say, no, what, you'll be slotted back. So that's one challenging thing there for me. And the most good thing about it is the fact that I work with a very good team. Like, who will tell me that I will ever come face to face with one of the best cardiology consultants in Scotland? I mean, the first time I met him, I was like, oh, I've read a lot about him, but I never thought I would meet the best cardiologist consultant in Scotland. I never thought I would see him face to face. And I was standing there face to face looking at him, and it was cracking joke. And I'm like, okay. So you meet lots of people, like, they share their skills with you. Even they don't look at you as you being just a mere nurse. They carry you along. They are good at teaching. I've gone in to observe so many procedures. So the good things are you know them, they carry you along. They allow you learn off them. They are willing to teach at any time. As long as you ask. If you don't ask, you don't get. So that's a good part of this job for me. And I think I made the right decision going into that department actually, because like I said, I knew bedside nursing was not for me. Being on the ward was not for me. But looking back now, if I have to go back again, I will always go back to where I work right now. I mean, that department, if it's available anywhere else, I don't know. But yeah, it's a better choice I made, and these are my good and the bad things about working there.
Wow, that's powerful. Thank you for
Yeah.
that. So
Welcome.
basically, you still see patients, but it
Yeah.
is not totally bedside nursing,
No.
like
No.
the normal bedside nursing. Okay,
Yeah.
right.
hmm
So generally, because I know a lot of people, we've got a lot of, I mean, I have a lot of overseas nurses watching me, and
Yeah.
sometimes they can just need clarity on, oh, so I'm considering whether to go to England or to go to Scotland.
hmm
Just can you give us like I know you are going to support Scotland and say come to Scotland. I
Yes,
know.
now. Yes, any day,
but
anytime.
but can you just tell us, what do you think about nursing in Scotland? Why should somebody, should I say, pick Scotland over England for their nursing
Mm-hmm.
journey in the UK?
Mm-hmm.
You can just try and give us a quick idea of what nursing in Scotland is,
Mm-hmm.
especially for people of our color.
Mm-hmm. So for Scotland, obviously I've always lived in Scotland. I studied in Scotland, and I think England is oversaturated, and most of their hospitals are really, really far. Like I know people who travel miles to get to their work. So I believe, regardless of where you want to practice nursing, we are still being regulated by the same body, which is NMC. But I will only speak for Scotland because I've never lived anywhere else other than Scotland. So I would say nursing in Scotland is still much better. Like I've heard cases of people being in hospital, patients being rowdy, patients being abusive, and all of that. I would say since I started my job where I work. By the way, my hospital is recruiting. If you know you're willing to to move to Scotland, let me know. We are recruiting big time because my hospital is
Are
just
they recruiting
expanding.
overseas nurses also?
Yes, in fact, we had a nurse who just came from I mean, from where is this place again? Was it not Dubai? I can't remember where they are now going now. Where all these expats are now going now? Is he? If I remember, I'll mention it. So she just came, and I mean, I see the support they gave her. Like she's really good. I mean, she was a recovering nurse, but then she's from abroad. She's an Indian, but she's from abroad. So we are recruiting, and I'm happy to share details of that if there's anybody interested. So I will always say nursing in Scotland is better. I will only speak for my hospital because I've only worked where I worked, and I've been to several hospitals during my placement, and I know for certain that I knew those hospitals I was for my placement that I don't ever want to work there. So,
Mm.
and I won't be naming the names of those hospitals, but like I said, I've only worked in my own hospital, and I can only vouch for my own hospital. I've had cases of other nurses working in another so in Scotland we've got lots of health bodies, social I mean NHS bodies. So we've got like NHS GGC, NHS Aran and Ayrshire. We've got lots of NHS boards. And I've heard nurses working in, let's say for example, NHS GGC saying they have a ratio of one nurses to 10 patients. And I've heard of other wards also in Scotland saying one nurses to six patients or seven patients. If you are a nurse in Scotland, the maximum patient you will get looking after at a time won't exceed 10. And if it exceeds 10, there'll be many more staffs on ground. But where I work right now, I've seen staffs on the ward, and most of them, the maximum they have is seven. No more than seven. At times I see them six, one nurse to five patients, which is enjoyment. That's why I would say come and work in Scotland as a nurse. So, and I will only speak for my hospital alone. I'm not going to vouch for any other NHS hospital in Scotland. I can only vouch for my hospital alone. Like the work environment is different. It's just special. I can't compare. In fact, other hospitals I've been to in Scotland, I don't even want a place where I work on the side because I really shouldn't be comparing my hospitals with all those hospitals. So yeah, Scotland is the best for nursing. I know the pay is not a lot, but trust me, your pay will go a long way for you if you're in Scotland because Scotland is cheaper to live in as compared to being in England. I hope you find that helpful.
Yeah, I think so too. Actually, Scotland is quite affordable.
Affordable, yeah.
Yeah,
Mm-hmm.
quite
Mm-hmm.
affordable. Right. Thank you so much for that. So now that we know more about the role of a nurse in a PACU unit, which is a
Yeah.
post anesthetic care
Care
unit,
unit.
also
Yeah.
known as recovery nurse or
Mm-hmm.
recovery a nurse in a recovery nursing unit,
Yeah.
what advice would you give to people who think they want to come through this path, who think they want to become a recovery nurse or a post anesthetic care nurse
Mm-hmm.
in England or in Scotland, and also
Mm.
advice regarding interviews for them?
Yeah. So becoming a recovery nurse is no different as becoming a nurse, a bedside nurse on the ward. You've gone to uni, you've studied nursing, all of your skills are there. All the skills you have, either you've been a nurse in London or you've been a nurse in outside of UK or you're coming from Nigeria. Maybe coming from a Nigeria might be a bit different. You might have to do some sort of exams. I'm not quite familiar with the requirement for nurses coming from Nigeria. But as long as you schooled and studied nursing in the United Kingdom, our skills are pretty much the same. you'll be regarded as a band 5. Only if you've taken additional courses, or you've gone for a master's, or you've gone for a postgraduate courses, then obviously that's going to give you another leverage above all band 5s. For me, like I said, I was a newly qualified nurse, and then I went into that post. I had an in-house training. I think I practically had training for giving IVs, training for giving medication. I couldn't give medication for 12 weeks because I was undergoing all of my training. So I had to take a training of giving IVs, medication, like moving and handling, lots of training, and it's still ongoing. So in terms of interview is straightforward. Like we always say, when it comes to interview, you just have to read the job description of the post you're applying for. As long as you're able to incorporate the requirements for that post into your personal statements, you will nail the interview. The interview is straightforward. Like, why nursing? Why post anesthetic care units? How do you deal with unruly patients? Or how do you deal with a patient who is deteriorating after surgery? Questions like that. And let's say, for example, how would you deal with a patient who's just arriving to recovery, and they are not responding? Obviously, at times they come out unconscious, and at times they do come out and the anesthetics will choke out their airway, their gedel, even though they are not fully awake. It's normal for such patients to not like wake up and lose consciousness again. So what would you do in that instance? The good thing about where I work is that it's like a massive hall. You are not on your own. Even at times when a patient come out into recovery and they've got a gedel in, you are not going to be left on your own. Another member of staff will come stand with you to make sure that person wakes up, and then you're able to recover their airway back. So it's an environment that is convenient to work in. So like I was saying, in terms of interview, you will nail the interview. You will nail the interview. All you have to do is read the job description, apply the job description to your personal statement, because I think my work, you are required to write like a personal statement or something. And then you just need to apply your skills, your dealing with patients, one-to-one communication, scenario questions. You need to be able to get answers to those, which I believe we all know how to do anyways. You will nail the interview. The interview is not hard at all. At least another colleague of mine, she was a year qualified before I started. She's joining me at my workplace, but she's going into endoscopy units. So you will nail the interview. And if anybody needs help with the interview, reach out to me. I'm happy to give you an hint of the kind of questions they ask. But trust me, the interview is not hard at all, because they are recruiting right now. They are desperate for more nurses, and they will take you in. They will take you in.
When me for I wanted to say when me for president, but no, when me for overseas nurses advocate in Scotland.
Thank you. Thank you.
So, where do you see yourself within nursing in the next 10 years?
Mhm. So for me, never say never for me, because I'm already high in going back. Actually, I was speaking to my manager a few weeks ago. There was this training about anesthetic program at uni. So I think it takes about 9 months. And at first, when I saw that email, I was like, I don't want to study again, Daddy. I've had enough. Like second degree, I'm at that age that all I'm thinking about is money. I don't want going back to school. But then I thought, in a nutshell, I want to add more skills, more stuff to my profile. So going on that course is like anesthetic training. Going on it will, I could decide I want to be a scrub nurse tomorrow, which I don't think I will ever do, because the theaters are freezing cold, and I'm a cold person, so I don't think I will ever be a scrub nurse. And
Did they not put on ITA?
for where? Ita for where? No, it's freezing cold, and they will give you several reasons as to why the theater has to be at that degree. No, me, I'm not. I'm outside. No. So I did reach out to my manager and say, I'm interested in that course. We're like, oh yeah, sure, that's fine. That she's going to find out to see how many of us are going and what funding is available. So I still want to go back to do my masters, and I don't know how soon that will be, because sort of money has to talk. Because as it is, I will have to fund myself. If I was actually working with another health board, because my work is a NHS Scotland, we are on our own. We are not under any health board. So we are more or less categorized as a private hospital, but still under the NHS. So we don't get funding for all these courses like that. So if I start to go do my masters now, they would not fund me. I will have to pay my fees myself. But if I were to belong to other health boards in Scotland, but the fact that I'm employed by them, they would fund my MSc while I work on the side. So in the next 10 years, never say never, I have it in plans of going back for my masters. So at least I could upgrade to a band 6 or a band 7, or going for the ANP advanced nursing practitioner. These are things I've got under my belt that I would love to do. But in all, if I decide that I don't want to be a recovery nurse anymore, I see myself in the community as a health visitor, which is like a band 7. So that's probably the job I will do till I retire. So maybe in the next 10 years, I'll probably be an health visitor, visiting babies and stuff like that. Because I once had that placement and I loved the experience I had. So maybe in 10 years' time, I could be an ANP or I could be a health visitor, either of the two. Or maybe possibly get specialized in as a cardiology nurse, because I love everything cardiac as well. But there's been a few happenings recently that I was like, I think I will stay away from cardiac just now. I've seen a few people pass away. Obviously their surgery did not work well for them. And it's kind of like, left me in a way. So I'm like, I'll just shy away from that for now. So yeah, that's what I'm thinking of 10 years from now, maybe sooner.
Thank you so much for sharing that with us. It has inspired me, and I hope it's inspiring somebody also who is watching.
I
So if
hope
people
so.
want to reach out to you,
Yes.
what are the platforms? What's your handle in all these platforms? Are you on Twitter,
hmm
Instagram, TikTok?
So I really don't. I was on Twitter, and then they changed to X. And being a Christian, it was just not getting with my spirit. So I no longer go on that. So I totally
Okay.
abandoned. I totally abandoned my page there. But if you type that mom of five, I'm sure you find me on Twitter. I am on Instagram as that mom of five, and I am also on TikTok as just doing me. So just doing me is JUSTDOINGMII. Just doing me. You'll find me on TikTok. I'm sharing all this stuff about nursing, lifestyle, and stuff like that. Jobs and helping immigrants settle. If you're in Scotland, you'll find me on TikTok. I'm also on YouTube as that mom of five, which I'm sure you might find my handle once Victoria uploads this video. And I'm also on Facebook as well. So Facebook, I don't know, you find me by my name, and I don't know, I don't think a lot of people know me by my name, anyways. And I don't know if I really want to leave that, but either way, Victoria, I know you. I might send you my link on Facebook as well.
Yeah, so I'll
So
just put all the names and links
yeah,
on the screen and
hmm
also in the description box for
yeah.
people to
So I'm on Facebook as Wemimo Modupe, my last name. Just type Wemimo Modupe. Once you type Wemimo Modupe on Facebook, you won't miss me. You'll find me there. I'm the only one. Maybe last word, just to say, you know what? Recovery nurse is the best nursing ever. It's not stressful at
Hey,
all.
what do you mean? What are you saying? What are you
Trust me, it's
talking?
the best. It's the best nursing. You don't work. You don't work weekends. You don't work
Oh,
Christmas. You don't work. No, I mean, I finished last this Christmas that we've just completed now. I finished work on the 20th, and I did not go back to work until the
wow.
29th. So obviously there's going to be a difference in the wages of those on the ward, but then it's not a lot.
Exactly.
You can easily do overtime to get that extra 400 back. So you only
How?
have to work.
Where? You mean do overtime in Pacu also,
Yes,
right?
now because we are short staff. I was just telling you now how yesterday 5 o'clock. 5 o'clock was my finish time. I did not finish until 8 o'clock because they asked me to do overtime. So now they are owing me 9 hours of toil. So I'm thinking, should I use this as toil or should I ask them to pay me, because that's like a whole day money. So normally my start time is 7:30 in the morning, and then 3 days in a week I finish at 5, and then one day of a 5 o'clock finish. So it's 4 days a week. I have one day off in the week, no weekends, no nights, no Sundays, and you only have to do one Saturday every 6 weeks.
Wow.
And the good thing is
That's
that
easy.
the
Yeah,
good
please
thing is
go on.
that once your patient goes into theater, at times some of because we have 16 theaters. doing different things. Now they are expanding. It's going to be 25, maybe in a few months. They've already finished the build. That's why I said they are recruiting lots of nurses. So in the morning, when you first get your first, so by 7:40, we go get the first patient. So let's say someone's going for a lab call, like a gallbladder surgery. It's going to take about an hour 45 minutes. An hour 45 minutes, you can sit down and drink your cup of coffee. Though after all the first set of patients goes into theater, we have like 2 hours at least. It's either you go on and do your Lempro, we go get breakfast half an hour. But at times that half an hour will lead to 40 minutes because we know none of the patients are coming out anytime soon. So you have like 2 hours to either, if you want to do your whatever it is you want to do, go on the computer and do something. But you're going to be in recovery, set up your base, all the monitors are switched on, everything is there, everything that you need is there. It's easy, it's like easy pace. Now we've just started the system whereby if you take your first patient in the morning, if it was theater 14, you took their first patient in the morning. Like me now, yesterday, my theater was theater 3, all general surgeries. There were 4 patients, but at the end of the day, they cancelled one. I only cared for 3 patients. And that was me, I was done. I was just, helping those whose theaters are still running.
If you continue like this, I might actually pack my bag from England and come and get job
So
in this
that's
your
why those
hospital.
people that I met there, they've been working in that hospital for 20 years. They've never left. They are not going to leave because you don't do. I mean, it's not as if maybe you are looking after 5 patients at the same time. The maximum patient I've looked after at once was 2. I mean, I've got my bay, a patient here, a patient here, and I'm not
So
left on my
basically,
own.
you say that the stress level is minimal.
There's no stress. There's no stress. Trust me.
So is this particular with just your unit or generally with the
Just my
hospital or
unit.
generally with
Just my
hospital?
unit, oh,
Okay,
just my unit. And by
right.
the way, the ward where we went to collect the patients, you can imagine. So if you are a nurse now and you have 8 patients, all of your patients are going to theater that morning. So let's say 4 of them gone. So you have 4 patients left. You'll be sitting down enjoying now because there's no patient to run after to go and give medication. Maybe when they come back to the ward, you want to keep up with the observations, medications, IVs, and stuff like that. And going back on the ward, especially those who are in surgical day units, they're enjoying because they don't do night either. They admit their first patient 7 o'clock in the morning and they discharge their last patient maybe 7:45. They are short overnight.
It's
So most
just
of their
like,
patients don't. Yeah.
yeah,
So
it's
it's
like
those
having
of
a night
them.
vibe.
So it's only those who do like normal proper bedside nursing, like maybe cardiology wards, cardiothoracic ward, those ones they are there. But then it's still enjoyment because maximum patient they can have on their side of the hall, maybe 7. And I've been on the ward and I see like this hospital that I worked at. Like I said, I can't compare with anywhere else that I've been to. It's like a jackpot. If you find your way in there, you won't work anywhere else. I'm telling you.
Right. So what will you say about the training that they give?
Yeah. So
Like,
like I
is
said, they
it
do
is do
they
they
do
do their regular training and all that?
all training. So
Especially
even if you've been working in another NHS board for 20 years and you come to my hospital, you won't be able to give an IV until you've been trained. So there was a time we had some agency nurses. So agency nurses, they are paying £50 an hour for the fact that they've not been trained by my hospital to give medication. So let's say when we give fentanyl IV, we give it neat. We don't mix it. All these agencies nurses are not allowed to give meds. So if they have a patient who needed IV or they needed DREM fluids, they can't put anything up. It is me and my other colleagues that we still have to do all these things for them. And I'm like, why are you getting paid £50? And I'm still doing all of your work for you.
exactly, exactly.
I'm
So
like,
what have they come to do? They do
exactly
the other
because
things except give
exactly
medication.
except they can look after the patient, but they can't give medication. So I'm like, why not pay me £50 an hour? I'm the one doing all of this work. So and still we still maintain our cool with them. We still treat them as part of us. So you get IV trained, all of your pumps, and most of the time we don't really do lots of infusions. If a patient ever comes out with an infusion, maybe it's metraminol and it's mostly made in theater. We rarely make it, but we have that training anyway. Should in case you are looking after a patient at some point and the anesthetist is not around and maybe heart rate is dropping, blood pressure is dropping, and nothing is stabilizing it, you just have to make up metraminol. Then you know what to do. Everything is there. Omnicell is there. You take everything out. So you get all of those training, and we get in-house training as well. And we also get one day in the month which is called CMED. Like no surgery, no nothing, nothing. Just come in, you do your training all day, and then you get the entire day to go to your Lempro or Turas. So it's you get trained, you get all of your training, and you take time, they take your time, they don't rush you at all. So even if you are giving drugs, most of these medications, fentanyl, morphine IV, oxycodone, there are two members of staff checking because they are something drugs. I can't remember what they are called now. So you have to be checked by two members of staff. So you are still not left alone on your own. So there's no room for you even committing errors. For me, when it comes to medication, I don't have any problem. My one is maintaining airway, wound, because when we get thoracic patients, they always, thoracic patients are patients who have had lung resection, lung surgery, so they often come out with a drain on their side. So those ones,
Yeah.
their care could be a bit complicated. So it's that one now that my head is around now. Like I'm not learning anything else, but their care. So it's like I said, it's you get trained, and training is ongoing. I mean, right now they've put my name down for ECG training. I can do ECG, 12 lead ECG. But when it comes to reading it, I can't be bothered. As long as it's not reading flat line, I know you are alive. So I'm getting that training soon. And this is a training that I did not get at uni. And no matter how your cardiology teacher want to teach you, or your human and anatomy teacher want to teach you, they're not going to teach you everything about the heart, the cardiology system. So I've been put up for that training as well. And all of these training are available as long as you're open minded and you're available for it. They'll put you forward for it. And for me, I'm open to all of the training because you can never tell when you will find it useful. And maybe if I decide to leave there to go work somewhere else, I know I've got all of this training with me.
Thank you so much, Webimo, for doing this with us today. Thank you, thank you, thank you. I've learned so much
You're
about
welcome.
pacu, and I'm sure that a lot of people have a better understanding of what
Of it.
a recovery nurse does in
Mm-hmm.
the United Kingdom, in
Yeah.
Scotland especially. So
Yeah.
thank you so much for coming. So I hope you guys find this interview very helpful. If you do, please like this video, leave me comments below, share this video with your nurse friends. And I've got other videos around different specialties in the United Kingdom. So you might want to check them out. I'll see you in the next one.